Medic 9 was dispatched to report of a 42-year-old male with chest pain. When they got there, they found him laying in his front yard. He was accompanied of members of Engine 3. He'd been mowing the lawn, experienced some pain. 12 lead was immediately performed, showing the possible anterior lateral STEMI. They gave him aspirin and a spray of nitro was administered. The 12 lead was transmitted and report was called via iHern. In the ED, the provider reviewed the EKG, and I'll tell you that we've reviewed this case between Nick and Dr. Jackson and myself. There's a bit of a question which EKG they reviewed, because they did one when he got here, which was a little bit different than the EMS one. So I was incorrect when I wrote this, because the EMS EKG, we're not really sure, because the EMS EKG was pretty clear. Our EKG here wasn't. So anywho, they did show cardiology was immediately contacted. The EKG showed some T-wave inversion with some slight elevation. I believe that was the EKG done here. Cardiology felt with that EKG, it wasn't meeting criteria for a STEMI. His troponin was normal. Patient was reporting some significant relief in his pain. So they planned for an admission with cardio to follow. The patient was admitted. The next morning, he started experiencing crushing chest pain, diaphoresis. He had some rhythm changes on telemetry. They did a rapid response and did an EKG, which then showed a STEMI. So he became an inpatient STEMI. He got taken down to the cath lab and found to have a 90% stenosis in the LAD and 90% stenosis in the mid. I think it was both in the LAD, mid to distal LAD. Both were successfully stented, and he was discharged 2 days later, following up with cardiology, dual antiplatelet therapy, statin, and cardiac rehab.
If I got to look at the screen.
Oh. See, I told you I messed up.
No, you didn't.
Run history, all the times were great. Obviously, there's some we didn't do the STEMI, but run history was great. He was pretty close. We don't have a first medical contact to balloon or union door to balloon because he was an inpatient. So this is the EMS EKG. And then that is the EKG here. This is his inpatient EKG the next morning. There is his cath. For 42 years old, his vessels don't look so great, but they got him fixed. So we got blood flow with 2 stents. Course and highlights, like I said, we're reviewing these cases. Everybody, Dr. Jackson, everybody's working really hard to get those EMS EKGs here so we can activate on those EKGs. And I know we have a meeting next week for some updates to eBridge, which I think will help. But rapid assessment on the scene, we did multiple 12 leads and rhythm strips obtained en route. So good job there. Any questions on that one? Case 2 is from Putnam County EMS. This patient called 911 for heart problems. EMS arrived to find patient in his driveway, pale and diaphoretic. He was gripping his chest. He had reported that he'd had 5 heart attacks, he had a heart attack in the past 5 stents. His chest pain was severe and radiated to his left arm and his jaw. The 12 lead EKG did indicate an inferior STEMI. They gave him aspirin. Medicus identified quickly that he would need immediate intervention. So rather than going to like the local hospital, they brought him straight to Union Terre Haute. They did call a STEMI alert ahead. Cath lab revealed a totally occluded RCA in the mid portion. There was a previous stent there in the proximal to mid segment of the RCA. That part was patent, and then immediately following there was a thrombus. So that was occluding the vessel. They did angioplasty and stent. He went to the ICU in stable condition, and he went home 2 days later. There are your run times, really great. Your first medical contact to balloon was 86 minutes, and the union door to balloon was 29. I did not have an EMS EKG for this one, but there are your cap images. You can see that RCA occlusion, and then the course and highlights. I mean, he came from a county where they could have just taken him to their own hospital, but recognized he needed to come for a PCI. So they did transmit the EKG, rapid assessment on scene, and they did activate it with his EMS EKG, which allowed us to have our reperfusion time under that 90 minutes. So
yes, this patient was probably on the far west side of Putnam County, because otherwise they could have went to Methodist. Coming from that.
Well, in the notes it did, there was some suggestion back and forth. I mean, I
Depending
think
upon where the patient lived and where it was located.
he must
within
have
the
been
county.
right there on the line, because they did end up deciding to come
Yeah.
here, but
that's fine.
anyway. Thank you, everybody.
Thanks, Brooke. Appreciate it. Any questions for Brooke? Okay, we're gonna move Miranda up a little bit. She's gonna do our trauma center, our trauma report now.
All right, good morning. Dispatch was to local ECF for a 95-year-old female. They said short fall and then bilateral leg injuries. Doesn't sound like a big deal. So you can see the run times here. The only thing that fell out was a 32-minute scene time. Which I think once we get into it a little bit more, you'll see why, but there was no documentation explaining it. So her patient was sitting in a lift chair, so she raised herself as high as the chair would go. She fell face first, and when she landed, her legs were, so she landed prone, but her legs were basically bent underneath her with her feet touching her clavicles. So it was documented in multiple places within the patient's chart. So she, like a sandwich kind of, is what it seems like to me. And she's 95 years old. So EMS, and she was left that way. So in the run report, they
Didn't move her.
didn't move her at the nursing home. So it was documented in the run report that EMS got there. They had to put the mega mover. They were able to like roll her over and then kind of splint her after that. So she just laid squished like this for, well, let's see, 911 call was 11:20, and then they were on scene at 11:35. So however long she felt prior to that. So C-collar, 1280 kg, they did an IV cardiac monitor. They treated her with some fentanyl. Her vital signs here, not terrible, but the heart rate's 120. But she kind of obviously deteriorates. So she arrived in the ER. So it was not called in as a trauma via EMS, and it was also not activated as a trauma on arrival to the ER. So she arrived at 12:25. ED physician was at the bedside at 12:34, and then at 13:39, they activated a level 2 trauma at that time. So there was documentation in the chart. The nursing home called report prior to. They said this patient was on, and it was a very benign like note in the chart. Didn't seem like anything exciting. And they said specifically no blood thinners or anything. But pharmacy confirmed her medications, and then she was activated for like head injury with she was on Xarelto. So I don't know how the nursing home missed that, but that's what she ended up being ultimately activated for, was fall on the head injury with blood thinners. But she could have been activated for multiple long bone fractures, major extremity injury, and then greater than 65. This is our stuff. This isn't anything that I would expect EMS to activate for, but. So labs in the ED, just basic lab work. Her hemoglobin was like 10.8, 10.1. Her white count was a little bit elevated. Her CTs were negative, no acute injury. The x-ray of the ankle just showed some tissue swelling. But then they kind of got squished here a little bit. X-ray of the bilateral knee, acute comminuted fracture of the distal right femur with posterior displacement of the distal fracture fragments. And you can see that on this side here. Oh, it's coming back this way. Acute fracture of the proximal right tibia, right knee joint effusion, soft tissue swelling, and then acute distal left femur fracture and acute proximal left fibula fracture with left total knee arthroplasty in place. So she just crumpled essentially. So of course we had requested admission. Ortho was consulted. Sister was at bedside this entire time, and she did request that this patient be a DNR DNI. So we were gonna send her back to the nursing home as hospice, which is what the daughter wanted. She did not meet GIP admission criteria here, which is like inpatient hospice here. So they decided after some discussion with hospice, they wouldn't be able to get the meds for her for pain control. So she was admitted here at the hospital overnight for pain control, and then she was going to be discharged back to the nursing home, which was family request. When hospice was able to get those pain medications. She was hypotensive, tachycardic the entire time that she was here. Ortho saw her. They said that they would be able to operate on her and fix, like, the injuries were able to be repaired, but she was high risk. So she had AFib with RVR, and she was her age and all of the things. So they ultimately made the decision that they would just do comfort measures for her. So we admitted her, and then it was kind of, a nurse upstairs went in to update the family that she was going to be discharged. This is what time TransCare is supposed to come pick her up and transfer her back. And then the patient actually took her last breath while the nurse happened to be in the room. So it's not anything crazy, but when I say that it's a ground level fall, we just kind of oh, it's whatever. We kind of just brush that stuff off. But this is essentially a ground level fall. She just raised herself up to a standing position in this chair, and then she fell. So I think we have to be open to the fact that these ground level falls can be way more serious than what they kind of start, what they kind of sound like to begin with. And so there's opportunity for everybody, ER staff included. So
Thank you very much. Don't see Beth. I'm gonna move you up if that's okay.
sure.
Well, Beth isn't here yet. She will be here. We're going to.
Mine will be longer than the strip one.
Thank you, Megan.
Yeah. So I'm going to talk to you guys about drowning today. Talked to you guys before, but in case anybody's new today, my name's Megan. I'm a nurse. I've been a nurse for 15 years. I started here at Terre Haute. I worked at Regional for the first 5 years of my career. And I went to Methodist for 2 years, worked there in their ER, and I've been transporting patients for the last 8 years with Lifeline. So I'm going to talk to you guys about drownings, just because kind of 'tis the season, right? I feel like drowning calls go up a little bit in the spring and the summer. And so it felt like the right time to come in and talk about kind of what you guys do in EMS, what we see in the ER, kind of how these differ a little bit from normal resuscitations. Because I think that is important to kind of talk about, just because it changes a bit. And so I think it's important to kind of highlight those differences. All of my lectures start with some disclosures. I'm an hourly employee, so I am getting paid to be here. But anything that I talk about, if I talk about any kind of equipment or anything like that, they are not paying me to talk about those things. Some of the discussions that I talk about, some of the lectures I give, I build a case study in. I don't have any really great drowning case studies, so I didn't build that in. But if we talk about any of your guys' cases, please treat them as protected health information. Let's not leave here and be like, hey, Miranda had a drowning the other day and she did this. Okay, so let's keep that in this room. And then any information I present is meant to be educational, and it's not my professional advice. Don't leave here and be like, well, my protocol says to do this, but Megan said to do this, so I'm going to change and walk off protocol. So let's start very simply with what drowning is. And so when drowning happens, water enters our airway and it disrupts our breathing. And so how drowning, or how death with drowning occurs, is with profound hypoxia. And I want you to keep that in your mind as we move forward, because that affects how we resuscitate these patients. And so I want you just to keep that at the forefront of your mind as we move throughout this entire lecture. Drowning occurs in two ways, either by submersion or immersion. So submersion, our mouth goes underwater and air enters our airway, water enters our airway, or immersion, water passes over our airway. That would be a very rare case for you guys, but I suppose you could still see it. So that would be like waterboarding. So something like that. And that's still something that we could see, but it would be a very rare occasion. So those two occasions. We used to have all kinds of classifications. Can you guys remember when we used to have like wet drowning, dry drowning, delayed drowning, near drowning, things like that? We've tried to really simplify this process, and so we only have 2 classifications now, and that's non-fatal and fatal drowning. Very simple, either they died or they did not die. So they were able to be resuscitated or they weren't, or they didn't require resuscitation. And so there are, we really try to not say dry drowning anymore. It's very clear we try not to say that at all anymore. And trauma programs across the nation have done really great work. Fire departments have done really great work in trying to prevent this. And it is a totally preventable problem, right? You wear your life jacket, you stay with your kiddo at the bathtub, but it is still the 4th leading cause of death in children. It's still an absolute crisis in the United States, which is a first world country. And I think that we have improved it by like 37%, but it's still happening. And so we're still going out on these calls. So I want to really kind of talk to you guys about how we can treat these people effectively. First and foremost, we're going to talk about kind of tailoring our approach. We should always remove these people from the water at the earliest opportunity, and kind of have a standardized approach, but understand that these people, each situation is going to be a little bit different as far as when they got removed from the water, right? So if somebody's removed really early in the process, it might simply be a little oxygen, a little warming. They might just have a simple like sputtering cough. We're just going to really monitor them closely. But if they're removed very late in this process, that's going to be a prolonged resuscitation. We're going to transport them into hospital. We're going to meet all of the ER staff. And it might be a very invasive warming process that they're going to have to go through. But knowing kind of how to assess this situation and noting your surroundings. So if we show up and it's a pool, that's going to be a different kind of story that we have to tell the hospital and where we need to take them. Or if this is a really kind of murky water, we notice there's a lot of thick algae in the water, or stringy plants in the water that they could have inhaled into their airway, knowing that we need to tell the staff that, because that's something they're going to have to maybe bronch out of the airway after they resuscitate them. And then, yeah, that's all for them. So the most at risk, I think that it's no surprise that the younger population is probably the most at risk here. And so about 57% of our drowning patients are under the age of 30. And this happens because of like low supervision. They're left unattended or under the supervision of a younger sibling. And again, that's something that is totally preventable, but that's not something that we can prevent before we get there. And so just knowing that we're probably going to be showing up for younger folks. Gender, sorry, males in the room, it typically is a young male. They just have riskier behaviors. I don't know why. It's just built into you guys. And so knowing that this is probably going to be a young male or an adolescent male, just because you guys like to do silly things to impress each other and impress ladies. And then poverty and the inequality that affects poverty, the people below the poverty line. Swim lessons, water safety classes do cost money. And if you have to choose whether you're going to feed your family or whether you're going to put somebody in a water safety class, you're going to choose to feed your family. There are programs here in Vicar County and all across the surrounding counties that are starting to do water safety classes at a discounted rate or for free, and that's wonderful. But until all of them are free, or the word is out that those things are discounted or free, this will continue to affect those at or below the poverty line. Another way that this affects those at or below the poverty line is occupationally. A lot of jobs on waterfronts or fishing jobs and things like that do not pay a ton of money. And so people who are doing those jobs are kind of at or below that poverty line. And those jobs are going to be at risk because they are waterfront jobs, whether it is just because they are on the water, weather that comes in off the water affects those a little bit at a greater risk, and then climate change. I'm not going to get up here and talk to you about political things and climate change a ton, but as the climate on our planet is changing, we are going to see more floods, and like 3/4 of the deaths that are related with floods are from drowning. And so as drowning deaths or as flood deaths or flood numbers go up, drowning deaths are going to go up as well. So precipitating factors. So I think that sometimes we have in our mind like an idea of what causes most drownings, and it's, you know, that swimmer that's out there doing a lot of swimming is getting fatigued or they go overboard. And when I was at Greene County giving this lecture for their audit review, Dr. Gamble very astutely asked the search and rescue guys, like, how many swimmers do you pull off the bottom of these waterways that have a life vest on or appropriately secured? And they were like, single one. And so the people who are going overboard on these boats are not appropriately wearing their swimming or their safety devices. And so it's not like if I know how to swim, I'm going to wear my life vest, especially because it's not cool on the 4th of July when I'm out on my pontoon boat. It's not cool to wear my cool swim or my cool safety vest. And so a lot of times, even if I don't know how to swim, unless I'm really scared, I'm not going to wear it. So a lot of times the precipitating factors are going to be medical causes. And so they might have had a medical event, or again, they're not being supervised in these areas. And in talking with these search and rescue guys and the E&R guys, shocker, a lot of alcohol is related to these events. And so especially Memorial Day to about Labor Day, you know, camping events, things like that. You're out drinking, you're out having a good time. Add in that a waterfront venue, and you've got a little bit of recipe for disaster. And so again, kind of, you guys are the eyes and ears of this. You know, we know when they get there to the ER, you can smell alcohol on it, but you know, if you show up and you're like, oh my gosh, there's beer cans everywhere. Hey, what was going on, guys? But then to also take a look and be like, do they have a medical bracelet on? Ask people on scene, hey, you know, do they have any kind of medical history? Oh yeah, they've got a history of seizures, or yeah, you know, they weren't acting right earlier today. They were complaining about their chest hurting or whatever. So I think it's important we talked about hypoxia is what causes death in drowning. And so how does that actually happen? How do we get to that profound hypoxia? And so when someone is drowning, you do a lot of breath holding, but we can't hold our breath forever because we have these chemoreceptors in the brain, right? And it's going to make us eventually take a breath. So after you've been holding your breath for a while and you're kind of bobbing up and down in the water, your body says you have to take a breath. And so your mouth might be kind of at that level of water, and you're going to open your mouth and you're going to try to take a breath in. And your body is going to have this really irrational thought. And you're going to say, okay, I either have to breathe this into my lungs or I could swallow the water that's in my mouth. And so at first you're going to try to swallow the water that's in your mouth. You're going to swallow a lot of it. So these drowning patients typically get a lot of water into their belly. So if you guys seen those videos online where they pull them out and they pump on their belly a lot, or we used to do it even, you pump on their belly a lot at the pool. So they end up with a lot of water in their belly. Eventually, you can't do that anymore and you have to take a breath in. When you take a breath in and the water crosses the back of your throat, what happens? What trick gets triggered? Anybody know? Yeah, you get a laryngeal spasm. And it effectively triggers this response, and it's a protective response so that you don't fill your lungs with water. and it clamps off the back of your throat. Which is perfect, right? Then you don't fill your lungs with water. What else can't you fill your lungs with? Air or oxygen. So you effectively shut your lungs off, but your body is still going to try to take a breath. And you're still going to have that like reflexive pulling in of air. And you're going to try. Eventually, hypoxia takes over and you're going to become unconscious. You'll become unconscious, you'll get limp, you'll start to sink. During this pulling in of trying to pull air, you'll pull air from other places inside your lungs. And that's where this non-cardiogenic pulmonary edema comes from that we see in drowning patients. You get foam and froth in the lungs. Has anyone seen a drowning patient? We see that foam and froth. That's where that comes from. Now, the water that comes into the lungs starts to wash out surfactant, but we haven't gotten a lot in there yet, right? We've only gotten a little bit across that. Now that's why we used to think that you could have dry drowning. Because you're unconscious, this is closed off, you're sunk, you're sinking. Remember the chemoreceptors, okay? They're gonna take over again. We become limp, we're sinking. The laryngospasm can only last so long. It releases, now we're totally underwater. The chemoreceptors say, you gotta take a breath, but we're totally underwater and now only water comes into the lungs. Washing out surfactant, filling the lungs with water. Now, I say filling the lungs with water, but really it's like 2 to 4 mils per kilo. Not a ton. So if it was me drowning, I'd be like 200 mils. If we shoot for the middle, like 3 mils per kilo. So like less than a 250 bag of water. Not a ton, but enough to effectively make ventilating be pretty hard, okay? That one is like my final breath of water. Laryngospasm happens again. I'm now fully underwater. Total hypoxia. And eventually, I can't breathe anymore. And it would be death. So in these lungs, water, a lot of times people are like, does it matter if it's fresh versus salt? You know, what's the big deal? Do I need to do anything special? Really, like tell the hospital. We don't need to do anything super crazy on scene if it's fresh versus salt, because again, it's only 200 mils. It's not like we're talking about like a liter of fresh versus salt water. But water is in those alveoli bases now, right? It's filling up those basements and making it to where air can't get through and diffuse. And so the problem is that now we're trying to effectively cross air through pond water, pool water, whatever, and it's set off this inflammatory cycle. So water is toxic to pneumocytes, the little cells that make up our alveolar membrane. And they're getting pretty angry. They're like, danger, Will Robinson, intruder alert, call 911. But they like call everybody. They call city fire, they call TransCare, they call mutual aid from every county, and too many people. And so now we have cytokines and neutrophils, and now our membranes are getting swollen and everything's there. It's too full. And we have tissue edema, and it's just too much stuff junking up this area. And now it's even harder to get anything to pass through those membranes. And so this makes our resuscitation harder. Not only do I have this 200 mils of water in there, but now I have all this extra edema and swelling in the area from this inflammatory cascade. Not to mention BQ mismatch and all these problems. Have we heard of BQ mismatch before? Yeah. Okay. I don't even have to explain it. So how do we start treatment? This is like the action portion of the lecture. We're going to start, again, standardized approach. We're going to walk up, BSI seat safe, and do our windshield assessment when we get there. Make sure everything's good. We're never going to go in the water, right? You guys have throw bags? Yeah? Okay, so we're going to do the throw bag. they're unconscious, somebody's gonna bring them to us, DNR will bring them to us, we're not gonna go in the water and become a patient ourselves. Once they get to us, we'll do our BLS assessment if they're unconscious. If they're not unconscious, you can do your primary assessment, right? But if they're unconscious, we'll do our BLS assessment. BLS assessment is what?
Airway breathing circulation.
Yeah, are they conscious? Do they have a pulse? Are they breathing? If they are, if they have a pulse but they're not breathing, what do we do?
Rescue breathing.
Rescue breathing. Yes, exactly. And if they are an adult, what's our rate? 1 breath every 6 seconds. If they are a child or an infant, 1 breath every 2 to 3. Excellent. If they are not breathing and they don't have a pulse or it's a weak pulse, start CPR, right? Now, this is where it is different. See them, cheater, it's up there on my slide. We're gonna start a little bit different. So, right, what's the cause of death in drowning patients? Hypoxia. And we don't know how long this patient has been super hypoxic. So before we start CPR in this patient, our CPR cycle starts with 5 inhalations. I think that it's really important to highlight that because it is abnormal from our normal CPR initiation. And this is national standard of CPR in a drowning patient. 5 inhalations, and then we're going to start normal CPR. On an adult patient, that is a rate of 30 to 2. On a child or an infant, that is 15 to 2. Because I hope to God nobody's showing up by themselves for drowning patient. I mean, I guess you could if you were off duty. Yeah, if you're out in the county by yourself. For an airway, you notice it says definitive airway. So a lot of CPR nowadays, a lot of resuscitations. What do you guys place them?
Yes.
I just. Would you consider that a definitive airway? I agree. So again, what did I say? What do we do at the beginning of drowning? Swallow a lot of water. So they are a humongous aspiration risk. And nigel cannot protect us from aspiration risks. So if your protocol, and I don't know what everybody's protocol is here, if your protocol says in a cardiac arrest, you place a nigel, fine, I'm not going to tell you not to do your protocol. But if you place an nigel and then you get some time on your hands, pull your nigel, place a definitive airway, which would be an ET2, because it is going to protect this patient from aspiration. Breathing, maximizing oxygenation and ventilation. I've talked to you before about this special little device that comes on all BVMs. What would that be? Huh? Peep valve, yeah. It is peep valve. And how would it help you out in this situation? Yeah, so we've already talked about this patient's gonna have like mad atelectasis. Okay. We are gonna just turn that peep valve up about 2 every couple minutes until we are getting about 92 to 96%. Okay. The fact that that is the standard for this patient tells me it's not going to be easy. Most times we're going up to like 98 is where our top goal is. The fact that it's only at 96 tells me not going to be the super easiest. And then circulation, CPR, warming them, and then following the appropriate algorithm, either ACLS or PALS, and supporting circulation. We've kind of already talked about this. Definitive airway, 92 to 96. Surfactant is going to restore in 48 hours. Because I said we washed it out a little bit. So if it restores in 48 hours, that means we have to maintain that peak that we get to for the first 48 hours. So maintaining peak. So if EMS turns that peak up and they get it to, let's say, 10 or greater, and then you bring them to the hospital, and the hospital goes and puts them on there. So what happened to all the recruited PEEP you got?
No.
Oh, it's gone. It disappeared. So when you get it up that high, and you've done all the amazing work you've done, before you hand it off to them, you're gonna go, whoa! I've recruited all those people. We are a PEEP of 12. I need you to clamp the tube. Because it effectively, your work was for naught. And they should listen to you. And clamp it. Okay? Because we need to maintain that peak for 48 hours. Okay? Using lung protective ventilation strategies, we've heard of ARDS before. It became like a humongous deal during COVID. That's essentially kind of the ventilation strategies we're going to try to shoot for during this period of time. So kind of low volumes with a higher respiratory rate. And I say low volumes because a lot of times we go, oh, they are 165 pounds. They must have 165-pound lungs. We know that our tidal volume should be based off what? Height, right? Ideal body volume or ideal body weight. And so just maybe, and that's a reminder that our lungs don't get fatter as we get fatter, okay? And then transferring to an ECMO capable facility. Just knowing that if this patient is this sick and we're having to do these kind of strategies, this might be like a short-term stop off before we need to get it to an ECMO capable facility. Because these people are going to be really, really sick.
Trauma one's on the ECMO facilities?
Not necessarily.
Okay.
Some like level 2s, level 3s, it just depends. Some places can start ECMO and then transfer out. It just, whether they can continue ECMO would be the question. But a lot of places can start ECMO. It's just whether they can continue ECMO. Circulation, we kind of already talked about this. Targeting a MAP of 65 is always going to be the standard. Recognizing a rhythm and treating it accordingly. So only about 6% of drowning deaths are going to be a defibrillation kind of algorithm on ACLS or PALS. That's still not zero, right? So we still want to prioritize pad placement while not kind of poo-pooing high quality CPR. But if we get one of those rhythms, we want to be able to defibrillate very quickly. So make sure that we are getting pads on as soon as possible. Judicious fluid resuscitation. Remember, their lungs are already full of fluid, but this is non-cardiogenic shock, or non-cardiogenic pulmonary edema. So knowing that we can kind of give them some fluid resuscitation, differentiating whether this is traumatic injury, doing a good trauma survey, kind of trying to figure out whether they need blood versus fluids. And then if they are not volume responsive, quickly moving over to vasopressor support. Some other things, in all of my lectures, I try to say, if you're really good at a GCS, if you're quick at it, do a GCS. If you cannot, and they are not doing, like if they're not posturing or having any really specific neurological symptoms, do an AVPU to get you through, right? Because if you are really bad at doing a GCS, that is just as detrimental as not doing one. Like if you say, oh yeah, they're GCS 12, and you come in here and they're a GCS 7, or vice versa. If you say they're GCS 7, you come in and they're GCS 12, it's just as bad. Okay, just do an AVPU, all right? And then you can arrive and they'll be like, no, they are only responsive to painful. That is great. Yep, we are on the same page. And then get out your GCS page and be like, okay, I can tick off where we're at. If you need to just do it off the top of your head for an IHERN, okay? And then if they are not like A&O and ready to go, do a finger stick on them to kind of get you a baseline. This was a stressful event. Their body is taxed. They're going to be burning through whatever glucose stores they have. Do all of these patients need C-spine precautions? Always consider it. If the shoe fits, right? Give them a little C-spine precautions. But like, if they were in the bathtub, do they need C-spine precautions? No, right? If they are out in the absolute middle of a lake and they just like off the side of the boat and didn't hit their head or neck on anything, do they need C-spine precautions? Probably not. Use your brains. You guys are smart people. If your protocol doesn't say that every single drowning patient needs C-spine precautions, don't do it. But if the story makes sense, the mechanism makes sense, put them in spinal precautions. Scuba diving injuries. So this is kind of more for our Terre Haute people, like our hospital people, because we do have Crane Naval Base in the area. I doubt our city folks will be going all the way to Crane Naval Base.
No, but we have divers on the city team. They might be in the.
Oh, okay, yeah, sure. So you guys know about Divers Alert Network? Okay, Divers Alert Network. So here's the hotline for Divers Alert Network. You can call them, this is their triage number, any time of day, somebody will answer that phone number for you. They will help you triage a patient. So an air gas embolism can present as a stroke. It can also present as just like really bizarre symptoms, like, hey, I can't pee. I'm having trouble peeing. Okay, Nick, well, I think you should see your urologist. And so if you get that patient and they're like, I can't pee, I dove yesterday and I've not been able to pee since like 2 hours after my dive. Call them. Call the hospital first, right? Like, we're gonna take you to the hospital, but call them and they're gonna help figure it out with you. They will help you find the appropriate treatment. It appears that most treatment for an air gas embolism is going to be, or air gas embolism like symptoms is going to be ECMO. But if it is a true air gas embolism with some kind of like spinal cord infarct or something like that, it is hyperbaric chamber. And they will find you a hyperbaric chamber to send them to.
We have one, don't we? We have one in the wound center.
But
I
actually
don't know.
dive them, because you have to dive them in it. And so to dive them in a hyperbaric chamber, they will find you one to do it, and they will find you transport to do it. Because like, if you have to fly them in an airplane, they'll find you the transport to do it.
Do you know where one are, like, close? That's just a random.
Dr. Les, our medical director, said the closest one is Milwaukee.
Okay.
The DNR guy said there's a closer one. He thinks it's Chicago.
Well, that's what I thought.
I wondered if there was.
I was gonna say, they said Chicago, and I was like, I would think that Dr. Les would know that, but maybe he just was unaware about Chicago. So, but they will get you transport arranged. They will do all of it for you on the back end so that you can just take care of the patient and they will do all of that for you. And they will give you any guidance that you need.
So wouldn't flight be an issue too because of the pressure changes?
So you'd be in a pressurized chamber
Okay.
and
So that's why you go.
helicopter
Well,
transport.
not all, because I used to fly fixed wing. Those aren't always, so you'd have to have the right plane.
And they will get you the right kind of plane.
Okay.
Like helicopter transport, we don't go high enough for
Right.
any of that. And so like if we would go to scene, like if we would go down to like crane and bring them back, we don't go high enough for any of that. And we would just have to be cognizant of it. But
So they have to have a pressurized cabin. Okay.
environmental exposure. This is gonna be, I'm gonna touch a lot more on hypothermic treatment in another slide, but obtaining a core temperature, and I know that every medic in here is like, gross. But like if you get an oral temperature and axillary temperature, I just know what temperature their mouth or their armpit is. So axillary temperatures are so biased on sweat and wet clothing and environment and all of that, that it's useless in trying to base hypothermic treatments off of. You have to have a core temperature. So you've got to get a rectal temperature in your ambulance. If you are coming to the hospital and they have the means of doing like a temp sensing Foley or an esophageal probe or a rectal probe or something like that, so you can get continuous monitoring, that's wonderful. But in your ambulance, it's going to be just a rectal probe. And then if you can consider gastric decompression, because we've talked about them swallowing so much water and air, we want to do that. So that number again. Okay, so hypothermia treatment. These folks are real cold sometimes. But remember that we like no water probably in Indiana except for really shallow water is going to be warmer than my body temperature. So any water that they're in is going to bring down their temperature. And so we need to get a temperature when they come out of the water, core temperature, when they get out of the water, so we can kind of base what kind of rewarming we need to do. And I think when I think of hypothermia that I'm like considering like Rose and Jack on the door of the Titanic, with like icicles hanging off of their nose and their ears, their eyebrows. But honestly, like any water in the state of Indiana is going to bring their temp down a little bit. So they could be mild, this first category. And that's not gonna be crazy. All you're gonna do is get their wet clothes off of them, put warm blankets on them, get them into your warm ambulance, and you should start seeing response. We aren't even talking about warm IV fluids at this point. It's literally just passive rewarming with air and blankets, but getting them out of wet things. Remember, then you have to get them off of their wet sheet that was underneath them as well, okay? Then we get to moderate, and I'm not gonna, like, you guys can read those temperatures, I don't need to read those to you. And this is a little bit more involved, this is gonna be warm fluids, getting them to the hospital, and we can do like the bear hugger, you could bring down like the ICU water blanket. That can run like warm fluids over them. It says the radiant warmer in this category, so that would obviously have to be with a child because we can't bring the radiant warmer over and put that over an adult patient. They are going to fit in it. But you guys know what the radiant warmer is, yes? EMS people in the room, yeah. No. So it's like the baby warmer.
There's one on the Pete's trauma, like if you, that sits in the corner of that little.
You've
bassinet
seen a
thingy.
baby in like the bassinet thing after they're born. It has hot, like, sun that comes down on them. It's like being in a tanning bed for a baby, but it doesn't tan them. It's just warm air, yeah. That comes down on them from a light bulb. Like sometimes our grandparents had like the warm light in their bathroom. That's what it reminds me of. That you could turn on like for when you got out of the shower. So there's that. And then you do warm IV fluids in that category. The severe category, and I have done this once. And it was when I was at Methodist. And this is like way, way cold. And so this is active internal rewarming. And so this is peritoneal lavage, warm with warm fluids, warm through your vent circuit. Again, and so each category, we're going to do the things in the previous category with it. So again, warm fluids, etc., all these things, but warm peritoneal lavage, warm vent circuit, ECMO. I don't want to miss anything in this one. It doesn't say thoracic lavage, but we did that. We did like Foley lavage with warm fluids.
So really, anyway, you could.
Put anything
Put
warm
warm in
through
and
the,
get it out.
through the body. Yeah. And the big note in this category is ACLS meds are ineffective until they are above 30 degrees. And so once they get to this, you effectively stop doing anything but rewarming them.
Yeah.
And these patients are incredibly unstable. The myocardium, once it starts rewarming up to this point, is so unstable that moving the patient can cause an arrhythmia. And so knowing that these patients, like moving them from your bed for EMS over to the ER cot could cause an arrhythmia. And so just knowing that these patients are slow movements, slow and steady movements. Just causing them to go into VF is highly likely here. This is tricks that we did with my one patient that I've had to do in this severe category. We put them inside a fluid containment bag and put the bear hugger in it and zip them up so that the air, we were only heating them then instead of the room and them.
That makes sense.
And like put the baked potato blanket in it and everything, trying to warm just them. Because they were cold.
The outcome of that.
Huh?
What's the outcome of that?
I mean, they were never in cardiac arrest, they were just hypothermic. And we got them warm enough to then go to the OR, I think, was the only goal of what we were doing, but.
I was just curious.
Any questions about hypothermia, warming, anything like that? Okay. Clearly, if you're giving blood products or anything like that, you would be warming those because cold blood products into a cold body is not
Ideal.
the goal. So EKG changes. Obviously, these patients are going to start a little tachycardic. It's just the reflexive response to stress on the body. Then they would become bradycardic, became hypoxic. and then a PEA or a systole kind of arrest. They could have, like I said, a 6% chance that they would have PF or pulseless VT. And then some things that you might see that would be like causes of this drowning issue or arrest: QT prolongation, AV block, supraventricular arrhythmias, and then things that might give you ideas of how long they've been down or ideas for treatment. So peak T waves would give you maybe an idea of how long they've been down, indicating hypokalemia or hyperkalemia. Clearly, you can't just treat off of peak T waves, but it might give you an idea when we come into the ER to say, hey, I've got some peak T waves on the EKG. We need to do a quick ISTAT. You know, I'm seeing this, just not like, hey, do a quick ISTAT. You can just tell them to do it, but hey, I'm seeing these. I think a quick ISTAT might be a good idea. And then an Osborne wave. Have you guys heard of Osborne waves before? Yeah. So Osborne waves are up here in this right corner. Sorry, Sarah, I'm going to move you down here just a little bit. So Osborne waves, so they're going to be this kind of upper inflection, and it's typically found in, I think, V5. But it is super indicative at less than like 30 degrees. Less than 32, like 80% of patients less than 30 degrees have a J wave or an Osborne wave. And so if we're seeing this, we know that these patients are very, very cold. If we're still trying to work on getting a temperature on them, the high likelihood that they're going to go into VF. And so knowing that we're going to have really prioritized pad placement on these patients, we're going to slow down our movements around them. We're not going to be jostling them around much. So again, we can't really do treatments off of these. I'm not just going to be like, they're going to go into VF. I'm going to go ahead and charge my defibrillator up, but I'm going to go ahead and prioritize pad placement. Peak T waves, I can't just go ahead and treat empirically hyperkalemia off of that, but I can know that that might be something that I can suggest to the ER staff that might be something that they would look for on H's and T's if this patient goes into arrest. Any questions about EKG findings? So a quick review, we're going to rescue them safely or have somebody else rescue them safely. Once they are rescued to safety, we're going to do our BLS assessment and determine the level of care needed. We'll initiate resuscitation, but with what step first before we're performing CPR?
5 ventilations.
5 ventilations before performing CPR. Thank you, Nick. And then we're going to start our high quality CPR cycle. We're going to prioritize ET tube placement before supraglottic if we can. And then we won't give ACLS meds if they are below 30 degrees Celsius. We want to warm them up as we talked about with that hypothermia scale. And then we'll support ABCs as we can. Thank you guys for your time today. Do you guys have any questions about drowning resuscitations?
Man. Nellis.
Thank you, Megan. We're gonna go back.
These ones up for you, right? Yes.
And Beth is going to come and do our stroke report. That'll be it. I've got a QR code at the end of this one, so just a few seconds and we'll be good to go.
Good morning, everyone. This is a stroke case that was from here at Union. History of this person, she was a 62-year-old female. She lived at home. She was independent, did have a previous history of a stroke, but she was able to get up, move around, lived with her family. Prior medical history: CAP, depression, cervical stenosis, COPD, CHF, hyperlipidemia, hypertension. Prior to CBA, she was a smoker and she was an AFib. Her list of medications were about this long. But the two that really stood out to me was she was on Xarelto and aspirin. EMS was dispatched to a local business by a bystander. Actually, it was a nurse. They activated EMS because the patient was complaining of chest pain. They gave her a nitro and she had a syncopal episode. On arrival, they found the patient was sitting upright in the passenger seat of the car. and she was alert and oriented. Her respirations were easy. As they worked her up, they realized, this is not a STEMI. But they were delayed at the scene because they had a lot of difficulty getting the patient out of the car, because she's a large lady. So they had to work to get her out of the car. But when they were able to get her out, they were able to pivot her to a cart. They put the cardiac monitor on her. It was sinus. Her GCS was 15. Her blood glucose was completed, but there was no number tied with it, but it was documented that it was completed. Blood pressure was 202 over 97, pulse of 75, respirators were 16, SATs were good, and they did get an IV of 20, a 20 gauge IV in her arm. During the assessment, they realized that it was left-sided weakness in both upper and lower, as well as a decrease in sensation in her face and her limbs. No slurred speech and no facial droop. They did establish her last known well with the bystander at about 1700 that evening. Here's her response time. EMS were noticed at 1732, dispatch 1734, and arrived at 1736, on scene at 41, and that patient at 43. Their leave times were 1756. They arrived at our ER at 1802. They followed the protocol great. It was directly to CT2 per EMS cart. Her NIH when she arrived was 4. They did do an initial stroke CT. They started out with the stroke workup, which was great. And it was negative for a bleed. But if you remember, she did have that chest pain on admission. That was her initial complaint. So they did work her up for aortic dissection. So we're going to take her back to get a CTA. And they did take her back and forth, and there was a lot of difficulty moving this patient. And we had a lot of trouble with blood pressure control in there. If you remember, that initial blood pressure was 202. It actually went up into the 220s. So they had to give several doses to control her blood pressure, because to give TNK, it has to be less than 180 over 105. The door to needle time with her was 1 hour and 56 minutes, but there was a lot of mitigating factors. Our timeline was great. They got her here. They recognized the stroke. They did everything they could, but then they did some extra testing to make sure the TNK was appropriate for her. It didn't end up getting admitted. And what's the big change with this? If you remember a little bit ago, I said she was on Xarelto. Xarelto is a DOAC. Usually that was a hard stop. We did not give TNK with those medicines on boards. And if you look at those DOAC drugs, these are drugs we have almost everyone who's on AFib on. Our stroke patients are on this a lot. I mean, it is now permissible to consider TNK with Eliquis, Xarelto, Pradaxa, and Savasa on board. So usually when you got that history of are you on thinners, and they said yes and named one of these meds, it was like no. But now we are seeing that these can be given. And the studies are showing that there is no, the fear for a lot of bleeding after these medications, but it's not been demonstrated in large studies. So now it's only a relative contraindication, not absent. This patient was admitted to ICU post her TNK. The MRI was completed, showed an old frontoparietal infarct, but no acute infarct or hemorrhage. At 05:55, she developed a severe headache in the right temple. So, they could give TNK. She already was anticoagulated. Do we have a bleed? They took her down and scanned her, and she was negative. But she did very well. She was discharged home, residual weakness, but it was improved after the TNK. I think she left with an NIH of 2, and it was mainly in that leg. So she did have some mobility issues. The initial focus of this case was a STEMI, but it was quickly realized that was not what we were dealing with here. EMS was great, so this is not a STEMI. We've got a stroke going on. The new guidelines, the new American Stroke Standard guidelines were used, and it had really good documentation by EMS and the teleneurologist about why the decisions were made and the testing that was ordered on this person. So I think it was overall a very good case, and we had a great outcome. So just put that message out there, just because we have that Eliquis, Pradaxa, those medications on board, these patients are still eligible for TNK now. So you need to kind of keep that in our forethought. I did want to let you know that our CTP perfusion studies go live at Clinton this month. So we are doing that, and we are now offering neurology rounding services at Regional and Clinton via teleneurology. So we do have those services now, which those have not had a neurologist to follow up with these patients. So we really are expanding those services in our community. So Regional will get the brain perfusion studies after we go live with Epic. We cannot integrate the services right now because the PACS system or some such thing, like the way they're set up. So we are really expanding our stroke services. So those patients that wake up or have an event didn't come, you know, we can get that T&K up to 9 hours now. I know like IU's giving it up to 24. We're not there yet, but so really think about that. So if you have a patient that's in that window, you know, and this is an EMS decision, I won't tell you to go against your protocols, but if you have a patient that's in that window, they're gonna need those specialized imaging services. And right now, Union is the place that does that until we can bring Regional live. So if you have someone who's maybe 5 or 6 hours out from the initial stroke, maybe think about what services are offered at what facility. I don't want you to follow your protocols, but you know, they have to have that imaging before we can give T&K in that longer window. So just put that out there. If you have any questions, I'll be happy to answer any questions on it. But it's a good case. Thank you.
I appreciate it. All right, guys, that's gonna be it. I have QR code for you. You know, sign in. Use this, sign in here. Don't forget that next month we are at the Lansbomb Center. 8 a.m. for advisory and 9 a.m. for A&R. Not sure who's gonna be speaking yet, but we'll find somebody by then. So, all right, that's all I've got. If you guys don't have any other questions, thanks for coming. I appreciate it.
And what?